Good morning, good afternoon, and good evening, depending on the time zone you all are in. Welcome to the scientific session on breaking new ground in sepsis diagnosis and management with non-culture-based tests. I'm Dr. Aparna Ahuja. I'm the Chief Medical Officer at T2 Biosystems, where I provide leadership and strategic direction for all medical, clinical, scientific, and regulatory activities. I am an active member of various laboratory and medical associations like ASM, CAP, and AMP, as well as an expert panel member at CLSI and inspector with CAP and ISO 15189. I am a known strong advocate of patient and healthcare worker safety with a career of almost 3 decades in laboratory medicine and medical affairs in medical device in vitro diagnostics. Dr. Goff is an infectious disease specialist pharmacist and founding member of the Antimicrobial Stewardship Program at the Ohio State University Wexner Medical Center and professor of pharmacy practice in the College of Pharmacy in Columbus, Ohio, USA. She received the 2019 OSU Distinguished International Outreach and Engagement Award for her ongoing work in South Africa and hospitals across 6 continents. Dr. Goff is one of the 25 global experts selected by the WHO to implement stewardship programs in low-middle income countries. Sepsis is a burdensome condition worldwide in terms of morbidity, mortality, and healthcare cost. Sepsis is the body's extreme response to an infection. It is potentially life-threatening medical emergency. Sepsis happens when an infection body triggers a chain reaction throughout the body. Without timely treatment, sepsis can rapidly lead to tissue damage, organ failure, and death. And it's well documented that early treatment improves chances of survival. Sepsis represents $62 billion in US healthcare cost, claims more lives each year than the 3 leading causes of cancer deaths combined. CDC data states that each year, 1.7 million adults in the US develop sepsis, 270,000 Americans die as a result of sepsis, 1 in 3 patients who dies in a hospital has sepsis. Another concerning fact is that hospitalized COVID patient as compared to hospitalized influenza patients faces a 22% higher risk of developing sepsis and is 113% more likely to experience septic shock. Antimicrobial resistance is on the rise globally and is one of the biggest public health challenges of our time. The CDC reports that each year in the US, at least 2.8 million people get an antibiotic-resistant infection and more than 35,000 die. That means on average, someone in the US gets an antibiotic-resistant infection every 11 seconds, and every 15 minutes, someone dies. The cornerstone of sepsis management is prompt administration of antimicrobials with activity against the causative pathogen. Indeed, delayed administration of optimized antibiotics is associated with progression from severe sepsis to septic shock and increased rates of adverse events, mortality, and healthcare cost. Extended time from presentation to appropriate therapy remains a major contribution to poor patient outcomes and proliferation of antimicrobial resistance. Current standard of care requires up to 3 days to provide species ID and susceptibility results, which can delay time-sensitive, life-saving targeted treatment. Survival decreases by 7.6% during septic shock for every hour delay in time to appropriate therapy. Also, prolonged use of broad-spectrum antimicrobials is a key risk factor associated with the development and spread of antimicrobial-resistant organisms. We know that rapid diagnosis and treatment could prevent as many as 80% of sepsis death. Today, we will discuss how culture-independent diagnostic tests could break new ground in diagnosis of sepsis-causing pathogens, enabling timely targeted therapy and appropriate sepsis management. The left side of the slide is the time of the sample collection when the blood is drawn from the patient. And it takes about 1 to 5 days to get a positive blood culture result. And The culture-based rapid diagnostic test can provide species identification in 1 to 3 hours, which is very good. However, that can happen only after a positive blood culture. And these tests cannot be leveraged until culture becomes positive and cannot be utilized in cases of culture-negative sepsis. Culture-negative sepsis is a common clinical concern where the patient appears septic with a lack of pathogen growth on culture. And the non-culture-based tests, which, like T2 Biosystems, are not reliant on culture positivity, or they're not influenced by antibiotic intake prior to the test. That's the advantage of the tests which are culture independent. T2 Biosystems diagnostic panel is the only CE marked and FDA cleared test that provides species identification directly from whole blood and within 3 to 5 hours of the first blood draw. The FDA cleared T2Dx instrument is a fully automated walk-away clinical multiplex benchtop diagnostic system capable of running tests directly from whole blood. Species specific results are ready in 3 to 5 hours very rapidly with no upfront sample preparation. It is very easy to operate. It's a fully automated with minimal hands-on time. Sample tube and a reagent tray snap onto a cartridge, which is then inserted into the instrument. And what you need is a 4 ml whole blood in an EDTA tube. And it's random access. So 7 individual random access drawers can be loaded at any time. No batching is required. And it is very user-friendly with a simple user interface. So I could say that this comprehensive product portfolio is very simple to use. We have T2 Candida and T2 bacteria panels with high sensitivity of 90 and 91% and specificity from 98 to 99.4%. Both are FDA cleared and CE marked. While T2 resistance was designated the FDA breakthrough device, and it is CE marked currently, and we are working on getting FDA approval. As already explained, in T2Dx, the instrument workflow, you need to put in the 4 ml of patient blood into the instrument. And then within the instrument, when the blood is inside and the reagents are inside, it lyses the cells, amplifies target DNA, and clusters nanoparticles. The clustering is detected as a change in T2 relaxation time of hydrogen nuclei in the sample. T2MR is a diagnostic detection method utilizing miniaturized magnetic resonance technology, which measures how water molecules react in the presence of magnetic fields. It is the first and the only detection technology that can quickly and accurately identify molecular targets within patient samples without the need for purification or extraction of target molecules, which simplifies the process, eliminates time and labor-intensive steps. Also, the T2MR diagnostic signal is not compromised or disrupted by the sample background, even for highly complex sample background, which is present in blood from patients suspected of having sepsis. It enables higher sensitivity as it enables measurement direct from patient sample. We have various products in the advancing pipeline, and to quickly mention them, T2 resistance panel, which I already said is CE cleared, but we are working on getting FDA clearance. It detects 13 antibiotic resistant genes from gram-positive and gram-negative pathogens in 3 to 5 hours direct from blood. There is a biothreat panel, direct from blood test panel for detection of 6 biothreat pathogens from a single patient sample. And both these panels will run on the current T2Dx instrument, while we are working on a comprehensive sepsis panel direct from blood test designed to detect 99% of all bloodstream infections caused by bacterial and Candida species and antibiotic resistant markers identified as threats by the CDC in a single test with a timed result of approximately 3 hours. This will be designed to run on next generation instrument, which is also under development currently. There is growing number of real world evidence of positive impact of T2 Candida and T2 bacteria panels on patient care and antimicrobial stewardship. Across hospitals, we note reduction in median ICU and overall length of stay, faster initiation of targeted therapy, as well as discontinuation of antimicrobials, and hospital savings. So these are four studies from 4 different health systems. And this is basically what has been seen in these 4 also, and there are many more which have been done. This is a publication which came out last month, and it is a meta-analysis of 14 studies evaluating antimicrobial and resource utilization with T2 magnetic resonance for rapid diagnosis of bloodstream infections. And here, the results were as follows: faster time to detection and species identification with T2MR by 3 days, faster time to targeted antimicrobial therapy for patients testing positive on T2MR by 42 hours, and faster time to detection to de-escalation from empirical therapy for patient testing negative on T2MR by 7 hours, shorter length of ICU stay and hospital stay by 5 days. Thank you. Here I come to the end of my session, and I will be handing over to Dr. Goff for her session on new era in sepsis management.
Thank you. I'm Debbie Goff, an infectious diseases clinical pharmacist, and primarily do global antibiotic stewardship, working with the World Health Organization, helping them to implement antibiotic stewardship programs in low middle income countries. I'm really excited to be a part of this presentation, and let's get started. When you look at the management of sepsis, this visual to me says it all. It's very easy to see that to improve survival in patients with septic shock, early appropriate antibiotic therapy is the key. Every hour counts. So if we get appropriate antibiotic therapy in within 1 to 2 hours, the patient has about a 70% chance of survival. And look what happens at the 24 to 36 hour mark, 9 to 5% difference or survival. So keep this slide in mind as we continue to move forward. In 2009, Dr. John Bartlett, who was a legend in infectious diseases, he passed away last year, but at a national infectious disease conference, he presented this as a keynote speaker, what he believed was a game changer in the management of infectious diseases. And up went our study, which was the first rapid diagnostic test with stewardship interventions in the management of staph bacteremia to show a difference in time to effective antibiotic therapy, length of stay in the hospital, cost of care, a mortality benefit. And he used this as the example. As he states, I selected the Ohio State University study because it shows a difference and felt it was a game changer. And what an ultimate compliment to our program, but importantly, the difference this made in patient care, and was my start to the journey of really being an advocate for rapid diagnostic tests, because I saw it firsthand many years ago on how it impacted patient care. And I asked myself, in using that rapid diagnostic test for staph bacteremia, we had to wait for blood culture growth in the bottle. So from the time of drawing the blood culture, that generally takes about 18 to 24 hours. And then we would have growth, put it in the rapid diagnostic test instrument, and in about 2 hours, we would have the organism identified. But I asked myself, what if we could identify a pathogen directly from blood at the patient bedside and eliminate that 18 to 24 hour wait for growth in the blood culture bottle? But back in 2009, that technology was not available. But it is now, and it is even more game-changing to be able to take it from days down to hours for direct from blood identification of organisms. So it shows the role of not only antimicrobial stewardship, of getting the right interpretation of a test, the right antimicrobial at the right time, but also the role of diagnostic stewardship. You need the right test done on the right patient at the right time. And the two, microbiology and stewardship, are a symbiotic relationship. One can't be done without the other. And that was really the beauty of our program. And that's what every stewardship program does right now is work in collaboration with their microbiologist. And we know sepsis, there's about 80% of sepsis deaths could be prevented if we actually knew what the patient was infected with. So it's all about timing. And I love this article that was published during COVID pandemic in 2020. So many people missed it. It's one of the most collaborative papers on antibiotic stewardship in an ICU. Many ICU physicians, as we started to roll out antibiotic stewardship, were really resistant and felt that, I know how to prescribe antibiotics. I don't need someone else helping me. And Rich Wonderick is an ICU intensivist at Northwestern University and was really not an advocate of stewardship. And he and I did many symposiums together, and he is now a champion because we have to function as one. And I think COVID taught us collaborative care is the way to go. And I really admire this paper published by him as the first author, Arjun Srinivasan, leading stewardship for the CDC, and the diversity of nurses, pharmacists. One of my pharmacists, Tony Glerlach, is our surgical ICU pharmacist, all co-authoring this paper about how to do stewardship in the ICU, where the majority of sepsis patients are going to be managed. And what I love about this is, why do they do what they do? It's fear-based. It's not a knowledge deficit. And that's really what drives excessive antibiotic use. And when you explore their own studies in the ICU, 30 to 60% of antibiotics are prescribed in an ICU that are either unnecessary, inappropriate, or suboptimal. Why would you prescribe an inappropriate antibiotic? Because you don't know what the organism is. And again, that's where a rapid diagnostic test really empowers us with that knowledge. So when I look at T2 bacteria, it shows it provides faster results. So an average of 3.8 hours versus traditional blood culture up to 24 hours. And so this study just concludes culture independent testing provides you with results far faster than waiting for growth in a blood culture bottle and then being able to identify the organism. So again, we go back to how septic shock in a medical ICU or surgical ICU is time sensitive. We know the management is outcomes are much worse as time goes on. So by the 9-hour mark, you're down to a very low percentage of odds of success if you do not have appropriate antibiotic therapy on board. But let's look specifically at candidemia, which has mortality rates of 53 to 98%. So if you delay effective therapy because you don't know what organism is infecting the patient and don't have source control, as this bar graph shows, you can see how mortality escalates quite rapidly. So the major obstacles in diagnosing invasive candidiasis are the blood cultures take so long to grow. Mean time to positivity is 2 to 3 days in the patients that actually have a positive culture. 50% of patients with disseminated Candida will never have a positive blood culture. And that's what creates the challenge for clinicians. So these two studies look at mortality rates in hospitalized patients with candidemia with delay in antifungal therapy. Why would you delay therapy? Because you don't know they have this organism. And you can see how it rapidly goes up from a 15% mortality rate to as high as 35% just 2 days into the treatment. And then Kevin Gary did this nice study looking at Candida albicans patients, days to start fluconazole related to mortality. So if you started on the day you drew the blood culture suspecting candidemia, you had a 15% mortality. If you waited till the culture result came back to definitively tell you on day 3 or longer, you see it's as high as 40%. So timing is so important. This study looking at T2 Canada access across some practice sites showed the difference in cost savings utilizing T2 versus standard therapy, and then mean duration of time to empiric antifungal therapy was 2.4 days versus 6.7 without it. So again, time is everything. So T2 Candida was helpful as an adjunct to blood cultures for the diagnosis of invasive candidiasis, along with antifungal stewardship. So again, the diagnostic stewardship and antimicrobial stewardship go hand in hand. T2 really can help identify patients with what we call the missing candidiasis, those 50% that have negative blood cultures, but because T2 has a higher sensitivity and specificity, it actually identifies patients that have candidemia that normal blood culture technique is missing. What I look at is how effective cardiology has really marketed door to balloon time. Every patient knows when they get chest pain, they better get to that emergency room fast, because if they have to go to the cath lab to open up their vessels, door to balloon time makes a difference in their survival. And it's time antibiotic stewardship programs market time to effective antimicrobial therapy. Cardiology states time is muscle. Sepsis states time is life. Every hour you delay effective therapy can result in a patient's death. So does it really make a difference to patients? Time to effective antibiotic therapy does make a difference in patient care. Ask the parents of Thomas Smith, who died of meningitis after a delay of antibiotic therapy. I look at two patient survivors of sepsis that I personally know. One was our patient, Jen Ludwig, at Ohio State University Wexner Medical Center. She was a student at OSU, 24 years old, young, healthy, perfectly fine, and developed flu-like symptoms and presented to our emergency room, and in 12 hours was fighting for her life. She spent a couple months in our ICU, developed sepsis. She was one of the first H1N1 patients, or swine flu. She survived, but in her courses of developing sepsis, her outcome was a double amputee of her legs and double amputee of her arms. This girl, I state, is larger than life, and she literally became a billboard, shown here, facesofsepsis.org. She is part of the Sepsis Alliance and an advocate for talking about the impact of sepsis on patients. You can see the picture of all of the healthcare providers that were involved in her care. She received at the time an investigational antiviral and really had a turn in her clinical case. And we shared that with her and presented that with her as she's shown here leaving our medical center. Just a great patient advocate. She is a speaker now to hospital CEOs advocating on the management of sepsis and how rapid identification is an important component of getting survival in sepsis patients, and really just a wonderful advocate, also a TEDx speaker, an amazing young woman. Mary Millard is also a sepsis survivor. Here she is speaking at the World Antimicrobial Resistance Congress. Again, really bringing the face to sepsis survivors. And it's so important. I learn so much from our patients. And these are two that have taught me so much, and really admire their willingness to share very difficult stories that they've personally experienced. But it's the reason we do what we do. Sepsis matters, and these two very strong women, outstanding speakers, bring the sense of reality of what it's like to survive sepsis. So to conclude, sepsis and rapid diagnostic test, timing is everything. The rapid diagnostic test has little value if the results are not acted upon rapidly. That's where a stewardship program becomes so important. Rapid diagnostic test with antibiotic stewardship interventions decreases time to optimal antimicrobial therapy, cost, and length of stay. Most importantly, it brings a lower mortality rate to our patients, and it's the reason we do what we do. Thank you.
Thank you, Dr. Goff, for your very interesting presentation. I have a question for you, especially with the many years of experience that you have in this field. Can you please share with us what you believe is the key impact of innovative, accurate lab diagnostics, which shorten time to result in sepsis patients? And also, maybe the top challenge that you face in the hospital while using these tests?
Sure, that's a great question. To me, when we introduced our first rapid diagnostic test, it was literally amazing to see the ability in 24 hours to be able to get a patient on effective antibiotic therapy and watch them get out of our ICU unit 2 days faster and go home alive. And so I saw an immediate impact on patient care and really became a strong advocate of rapid diagnostic tests based on our very first test, which was staph bacteremia. And that is a really bad disease. It's one that one of the bacterias that results in sepsis in many patients. So, it brought us closer to our ICU physicians because they also saw it. So it was really fun to teach them, hey, we already know what the organism is, and this is what we need to change their antibiotic therapy to. And they're like, already? So it was fun to teach this new technology to all of our physicians. And so instead of us, as time went on, instead of us as the clinicians calling to say, hey, your patient has MRSA, they're like, oh, I already identified that and I've already switched my antibiotic. It was really neat to watch them learn the impact of this. And then we added additional rapid diagnostic tests, and pretty soon, it became a full-time job trying to keep track of all these documented positive cultures and getting people on correct therapy. But what's equally amazing is that you bring new technology in, no matter what it is, there's a cost involved, a real dollar cost that your hospital CEO has to sign off on. And one of the biggest challenges that I've observed in hospitals across the United States and worldwide is when you go to make a case to bring in new technology, they want to know, what's my return on investment? And it's amazing to me to look across the US how every hospital doesn't offer a rapid diagnostic test because they, quote, think they can't afford it. And I'm like, you can't afford to not offer it. And there are so many studies at this point that look at the cost. And if you notice in our paper, that was one of the first, we included an economic analysis because I had to do that. I knew that this was a big increase in our microbiology's budget, but I said, nope, the stewardship program will cost justify it, because what does it cost to manage a staph bacteremic patient? What does it cost to manage a patient with candidemia? Those are not $1,000 price tags. They're upwards of $100,000 or $50,000. So I knew we could show an impact in cost, but more importantly was really survival of patients and time to effective therapy. Everybody in an ICU knows is what is the deal breaker for patients with sepsis. And to me, that was the most important thing. So we were able to get our physician champions on board, and it's just been an amazing journey, and one that I still strongly advocate to this day, because now we have so many different rapid diagnostic tests to pick from.
Thank you so much, Dr. Goff. And I think you really provided us so much of insights, and seriously, non-culture based tests could impact and break new ground in sepsis management.
Agree.